All right, so just gonna give Krista another moment to get on, but so this is gonna be our last lecture for our summer session. Yay, we're at the end. Next week we're gonna be doing our research pathology presentations. So we're actually gonna be coming into Riverside to present our pathology presentations. We're gonna do our presentations, then we'll have quick scanning applications lecture, and then we can jump right into scanning, finish up, hopefully finish the day a little earlier next week. And then that's it, essentially the end. I'm going to put together some, I guess, study guide questions for this class just to help you review a little bit. In terms of the final, it's not going to be anything crazy, just kind of like basic stuff like, most common lesions, basic measurements for like, pyloric stenosis, interception. Hey, Chris, I was just mentioning that next week we're going to be actually coming into Riverside for our pathology research presentations.
Okay.
Just make sure you upload your PowerPoint onto D2L under the assignments tab.
Mm-hmm.
So everyone just upload your PowerPoint so we have them on file so we can pull them up here. And then we'll go after that, we'll take a little break, get right into scanning applications here, and then scan lab, and hopefully get out of here fairly quickly. And then that's going to be pretty much the end of the semester. Just finish up that last abdomen comp, and then the final is going to be basic stuff. I'm not going to go into a lot of this detailed anatomy and stuff. It's going to be like, any images that are going to be on the test are going to be posted on D2L. So you'll see the images already. And then it's just going to be like basic, like most common lesions for like liver and kidney, common lesions for the adrenal glands. In terms of like hips, your basic measurements and your basic landmarks like femoral head, acetabulum. It shouldn't be too bad. I think you guys are going to do just fine for this. All right, so let's just get into our final lecture, which is infant hips and spine. Share screen. All right, so infant hips and spines, these are structures that we can actually visualize quite clearly with ultrasound. So we use our high frequency linear transducer, and we can get very detailed images for the neonatal spine and the early infant period. So these are newborn babies. So we do these examinations to rule out several different pathologies. The main one being a tethered spinal cord. But it's also used in the detection of occult dystrophic conditions, and is equal to sensitivity to MRI in terms of imaging quality. So it's a very useful tool. It's much cheaper than MRI. It's much quicker than MRI. As we know, MRIs, take a long period of time and are very can be degraded severely with a little bit of movement. So it's very difficult to keep a baby still, as you know. So ultrasound is very useful for imaging these different pathologies and conditions. So spinal dysraphism include a wide range of developmental anomalies of the spinal canal, which are broadly divided into two categories, open and closed types. So when we talk about closed dysraphisms, that's going to be any spinal abnormality that has a skin covering, whereas open dysraphism, there's just a thin membrane and no skin covering over the anomaly. So that's going to be like your myomeningeal seal that we get into. So Neural tube defects are a type of spinal dysraphism involving an absent or incomplete closure of the neural tubes. The severity of spinal cord defects or neural tube defects can range from mild spina bifida occult to severe spina bifida aperta. Open spinal dysraphisms have a skin defect with neural tissue exposed to the environment. So that's what I was talking about. There's no skin covering over these neural tube defects. So they're open. You can actually physically see it. There's just like a thin membrane over the skin defect. Since spine sonography is contraindicated when skin is thin or no longer intact, occult or closed conditions are more commonly examined. Certain lumbrosacral stigmata or signs or cutaneous back masses or midline deformities are known to be associated with spinal dysraphism. So most commonly, that's going to be your sacral dimple. So clinically, infants may present with a dimple on the posterior surface of the body along the spinal canal. Although it's not uncommon for the buttocks to contain a shallow dimple near the anus, at times the dimple may appear unusually deep or asymmetric. The dimple may also be suspicious if it is more than 2.5 centimeters above the anus or larger than 5 millimeters. So that would be a dimple, that's located higher up along the spine. So it's above about 2.5 centimeters above the gluteal cleft, or a larger dimple that's greater than 5 millimeters in diameter. In addition to in addition to a sacral dimple, a couple other, midline deformities could be potentially an imperforated anus, a tuft of hair, like a big patch of hair along the sacral spine. So these findings may suggest the possibility of an underlying maldevelopment of the spinal cord or the adjacent elements. So sonography is used to determine the relationship of these stigmatas to deformities of the spinal canal. So in the clinical setting, when a baby is born and it has an unusual sacral dimple, they'll send that baby to the ultrasound department to get a spine ultrasound. So embryogenesis, so this is a little A&P. Defects of the spinal canal occur in the first 8.5 weeks of life as the fetal nervous system develops. The neural tube and subsequent spinal cord arise from ectoderm cells. The surface of these ectoderm cells separates from the neural tube, with mesoderm coming to lie in between the neural tube and the ectoderm. Mesoderm forms the bony spine, meninges, and muscles. If there's incomplete separation of neural tube from the ectoderm, this may result in cord tethering, diastematomyelea, or dermal sinus. Premature separation of the cutaneous ectoderm from the neural tube can result in abnormal mesenchymal elements, such as a lipoma formation between the neural tube and skin. If neural tube fails to fold and fuse in midline, defects such as a myomeningocele can occur. Disorders of distal cord may lead to fibrolipomas of the phylum terminal. So some A&P, anatomy of the spinal cord and the vertebral columns. So the vertebral column extends all the way from the base of the skull to the tip of the coccyx, along the posterior surface of the body. It is the central bony stabilizer of the body. So we know that the spinal cord is, what holds us up. Within vertebral cavity lie the spinal cord, roots of the spinal nerves, and the covering meninges. So this is important. The vertebral column consists of 33 vertebrae. So it's important to know your numbers. You have your 7 cervical vertebrae, your 12 thoracic vertebrae, and more importantly, remember these 2 numbers, your 5 lumbar and 5 sacral. Because when we start doing these spine ultrasounds, for me, it's easiest to start in the sacral spine. That's the lowest portion. So you visualize the coccyx and you start counting your sacral spinal vertebrae and count up to your lumbar, to that thoracic lumbar junction. And that's how you determine, where, if there is a tethered cord based on how low down the cord lies. So we'll see that in a moment. So there's also 4 coccygeal fuse bones. There's pads of fibrocartilage called intervertebral discs that are found between each vertebrae and allow for flexibility of the spine. So if we look at our chart, so this is going to be the area that we're focused on from our coccyx all the way down here up to our basically our T12. So this is the section of the spine that we're going to be assessing when we do our ultrasound, this lower portion of the spinal cord. So each vertebrae consists of a rounded body anteriorly and a vertebral arch posteriorly. So enclosing a space called the vertebral foramen, through which a spinal cord and its through which run spinal cord and its covering. The vertebral arch consists of a pair of cylindrical pendicles, which form the sides of the arch, and a pair of flattened laminae, which complete the arch posteriorly. The vertebral arch gives rise to 7 processes, 1 spinous, 2 transverse processes, and 4 articular processes. 2 superior articular processes of 1 vertebrae arch articulate with 2 inferior processes of the arch above, forming 2 synovial joints. So that's how they get their name, because they articulate with one another, creating joints to give the spine that flexibility and movement. The pendicles are notched on their upper and lower borders, forming superior and inferior vertebrae notches. On each notch, the superior notch of one vertebrae and the inferior notch of the adjacent vertebrae come together and form an intervertebral foramen. The foramina serve to transmit spinal nerves and blood vessels. In neonate, problems typically occur in lower back area near the lumbar vertebrae and sacrum. So while sonography is performed from the back, the anterior vertebrae bodies appear echogenic and lie posterior to the hypoechoic spinal canal. The cartilaginous posterior spinous processes appear hypoechoic, allowing for visualization of the canal when scanning directly over them. The laminae are seen when scanning slightly off midline and appear similar to the overlapping roof tiles. So here you see those processes, the pendicles. These are intervertebral discs. So these echogenic areas here are actually your vertebral body. So this is what you're going to be counting when you're doing your spine ultrasound. So this is your spinal cord, your central canal. This is area is called the conus medullaris. So how it comes and tapers to a tip. Can't really see it too well here, but coming off here, you have your phylum terminal, which extends down. Oh, sorry. You can see a little bit better now. So the terminal phylum terminal is a thin two echogenic structure. I'm not echogenic, linear. It appears as two echogenic linear lines, it's tubular structure coming off the conus medullaris. So this is a transverse presentation of your spinal canal. So this is your central spinal canal getting towards that conus medullaris, that tip. So these are muscles. These are those processes, the arches, the vertebral arches. So the sacrum consists of 5 bones fused together. The upper border articulates with the 5th lumbar vertebrae. A narrow inferior border articulates with the coccyx. Laterally, the sacrum articulates with the 2 iliac bones to form the sacroiliac joints. Anterior and upper margins of the first sacral vertebrae bulges forward as posterior margin of pelvic inlet. This is also known as a sacral promontory. So in this picture, you could see your sacral vertebrae beginning. So this hypoechoic area is going to be your coccyx. Or this is actually the rectum, seen posterior to the coccyx. So vertebral foramina are present and form the sacral canal. Laminae of the 5th sacral vertebrae, sometimes those 4th, fail to meet in midline and form sacral hiatus. So you could see failure of diffusion of the sacrum, forms the sacral hiatus. Here's the coccyx. So this is just another picture and sagittal view of the spinal canal. So this is DS is the dural sac, which contains cerebral spinal fluid. So this was a picture that I'd found that I liked that showed your structures when doing your spinal ultrasound. So it's oftentimes useful to acquire this panoramic image to be able to, present to the radiologist exactly where the conus medullaris terminates or ends, because that's going to be critical in determining whether it's normal or whether there's a tethered cord present or some sort of spinal abnormality. So over here you see your coccyx, your hypoechoic coccyx, and you start counting your echogenic vertebral bodies. So S5, so that's why it's important to know your numbers, that there's five sacral, 5 lumbar, and 12 thoracic. So your S5, you count backward 4, 3, 2, 1. L5, so the L5 S1 junction is where you get this bending, so that you see the sacral junctions, tailing more posterior. And this is that lumbosacral junction. So that's another, can potentially be a landmark where you see, the bending back. So then you get an L5, L4, L3, L2, L1. And then T12 can also be located by locating the 12th rib and then scanning back posteriorly following that rib where it articulates with the 12th thoracic vertebrae. So you can, for me, it's easier to start the sacrum, working my way back. Some people try and locate that last rib and start there, mark that as T12 and then count down. So other landmarks, you have your spinal cord, which comes to a tip, which is called the conus medullaris. The central canal running within the cord. The filum terminal extending down off that cord. This area of cord that hangs down, this bundle of nerves, is also called the caudae equinae or caudae equinae. You can see the pendicles. So these are nerve roots. All right, so the spinal cord. There's cylindrical grayish white matter that begins at the foramen magnum at the base of the skull, where it's continuous with the medulla oblongata of the brain. It terminates below in adult at the lower level border of the first lumbar vertebrae. In younger children, it is relatively longer and ends at the upper border of the third lumbar vertebrae. So that's going to be important when we're doing our spinal ultrasounds, that that conus medullaris, or that tip of the spinal cord, does not extend past the L2 vertebrae. Because then if it extends past that L2 vertebrae, that is an indicative of a low cord or a tethered cord. So inferiorly, it tapers into the conus medullaris, from the apex of which there's a prolongation of pia mater called the filum terminal, which descends to attach to the back of the coccyx. Has a deep, long fissure in midline anteriorly, and anterior median fissure, and on the posterior surface, a shallow furrow, the posterior medium sulcus. So spinal cord is hypoechoic with a slightly echogenic borders and an echogenic line extending longitudinally along its midline. It's surrounded by cerebral spinal fluid. The central echogenic complex represents and is close to the cord's central canal. So that phylum terminal is appears echogenic and should measure less than 2 millimeters in thickness. A normal variant to be aware of is a filar cyst. Small cysts in the phylum terminal might be remnants of terminal ventricle or an arachnoid pseudocyst and have no clinical significance. So this is just a picture showing the spinal canal with the central canal, the double echogenic lines. So again, this is again showing the spinal canal, the conus medullaris, where it comes to a point. So this is a good indication of a normal spinal ultrasound spinal canal. You can see the conus medullaris terminates in the upper portion of this L2 spine. So if this conus had extended down past L2 and was getting into L3, this would be considered a low-lying cord, which would be indicative of a tethered cord. And another thing to notice too is that it's lying anteriorly. So this baby is lying on its stomach. The back is up. So this now cord is dependent. So it's it's lying down. It's going where gravity is taking it. So this is the baby's back. It's lying anterior. So this cord is going to be free moving. So you'll actually visualize in real time it pulsating with pulse. So you'll see it's line dependent. So that's also an indication that this is a normal cord, that there's nothing pulling on it, no mass further down, or no issue potentially, with Chiari malformation and pressure in the brain that's pushing this cord inferior. This is an example of that phylum cyst or that filar terminal. You see a cystic structure within it. So this is the echogenic continuation of that conus medullaris and should measure less than 2 millimeters in thickness. So 2 millimeters is that upper limits. So anything less than 2 millimeters is normal, equal to or less than 2 millimeters. So again, if you were to do your assessment of this, you see the conus medullaris, it comes to the tip. So you're looking where it comes to that tip. So this is L1, L2. So it's again within that L2 vertebrae. So this is normal. So it doesn't extend past that L2 vertebrae again into L3. So roots of the spinal nerves, there's 31 pairs of spinal nerves are attached along the length of the spinal cord. Nerve roots unite to form spinal nerve. Lower root nerves together are called the caudae equinae. So that's that bundle of nerves that extends past the spinal cord, extending down, caudae equinae. So dura mater is the most external membrane. So these are the meninges of the spinal cord. It is a dense, strong, fibrous sheet that encloses spinal cord and the caudae equinae. So dura mater is that external membrane, continuous through the foramen magnum with the meninge layer of the dura covering of the brain. Inferiorly, it ends on the phylum terminal at the level of the lower border of the second sacral vertebrae. So arachnoid matter is the delicate impermeable membrane covering the spinal cord and lies between the pia mater internally and the dura mater externally. It is separated from dura mater by a subdural space. which contains a thin film of tissue fluid. It is separated from pia mater by the subarachnoid space, which is filled with cerebral spinal fluid. Pia mater is the vascular membrane that closely covers the spinal cord. It's continuous above the neck through the foramen magnum, with the pia mater covering the brain. Below it fuses with the filum terminal. So you can see D is that echogenic fibrous layer, the dura mater. And then you have the subarachnoid space, the layer of the pia mater. All right, so sonographic evaluation. So due to incomplete ossification of the posterior spinal elements, we're able to perform this exam. So it's done from the posterior approach. So we're gonna have the baby lying on its stomach, or you can potentially have the baby decubed. If the baby's really fussy, you can even do it with the baby sitting up, like sitting up and kind of arched over. You can do it, the exam with the mother even holding the baby, against her chest, as long as, the spine is exposed. I like to have the baby prone or in a lateral decubitus position. You could roll a small pillow or a rolled towel, to keep the baby in position. I like to have a little bit of flexion of the spine. So a little bit of bending forward to separate the posterior spinal elements. Slight elevation of the upper body to distend the caudal aspect of the thecal sac. So what do you guys think of this one? Does this one look like a normal spinal canal? Or what layer, what number is this? So which spinal level is this conus medullaris terminating in?
At L2.
L2, so let's see. So 5, 4, 3, 2, 1. 5, 4, 3, 2. Perfect. Yep. And that's going to be 1. This is going to be T12. So this is where you see this panoramic view comes, very handy and useful. So again, so you're looking where that tip, the anechoic tip is, where that lies. So don't focus on this echogenic tip. You're looking just at that anechoic tip, where that anechoic tip comes to which vertebral column. Because below this is going to be that filum terminal coming off. So scanning is performed in the mid-sagittal longitudinal plane, as well as you get axial transverse views. The longitudinal images are obtained directly over the spine unless the infant is older and ossification obscures this view, in which cases a parasagittal approach is best. So you come kind of at an oblique angle. So transverse images are taken mainly between the spinous processes. Orientation of the probe is the same as in the conventional abdominal imaging. So you want to be perpendicular. So transverse view, let's see. I get transverse. Sure. Of course not. Sorry. share. So here's our transverse view. So again, this is our spinal cord, the central canal. So you can actually see nerve roots coming out. So this is your dorsal. You can see a ventral nerve root coming out over here, your dura mater, some of the cerebrospinal fluid. So you're going to be taking a series of transverse images between those spinous processes. Essentially, you'll start, at around the T12 level and just work your way inferior and continue down, until you see the conus medullaris and the terminal phylum terminal. Some places will actually have you do cine clips, just kind of, progressing in transverse as opposed to still images. So again, depends on your lab, what their protocol is. So for spinal canal, so we scan the sacral region first, where the canal is easily identified by stepwise ascent of the sacral vertebrae elements, and then follow the spinal canal in a cranial direction. So we're going to start low and work our way superior or cranial. Again, remember, if this is ordered because of a soft tissue mass or some sort of mass or lesion that they see along the spinal canal, there's an unusual bump or mass or lesion, you may have to use a standoff pad to better examine that soft tissue lesion. So maybe they're feeling like a lump or a mass, maybe it's a lipoma that they're feeling underneath the skin. So in order to visualize or better visualize the superficial structures, utilize a standoff pad. If you don't have a standoff pad available, you put a big dollop of gel, make your own standoff pad using a big ball of gel or gloop of gel. So dura, so echogenic lines just internal to the osseous borders. The spinous processes appear as inverted U's. The laminae seen when scanning slightly off midline, they look like overlapping roof tiles. And the coccyx mostly are completely unossified and is hypoechoic. So the single most important determination is usually at the level of the tip of the tapered conus medullaris. Normal level of the lumbar. This is the normal level of the lumbar canal is above the superior end plate of L3, with most chords ending in mid L2 level. So it's got to be above that superior border of L3. So you can have a chord that ends kind of like, between the L2, L3. At that point, it's kind of borderline. It could be up to the radiologist to determine if it's truly low lying. They may want to come in, take a look itself. But again, you're going to document, take multiple images showing exactly, counting the rib spaces, ensure you get a nice panoramic image. So lumbar vertebrae level may be determined several different ways, is often achieved by counting cranial from the caudal end. So that's the method that I like to use, start caudal as low down, start S5, S4, S3, S2, S1, L5, through L1. So some people go from the thecal sac usually at S2 or just beyond the coccyx, starting at S5. The last echogenic structure in the sacrum. This is the last echogenic structure in the sacrum is S5. Or from the lumbosacral junction that where I mentioned you saw like that tilting, change in direction of the spine where it moves more posterior. So that's that lumbosacral junction between L1 and S5. Again, panoramic imaging is especially helpful for these methods. So this is going to be that lumbosacral junction between S1 and L5. Or you can go from that last echogenic structure and count caudally. I'm sorry, cranially. So S5, S4, S3, S2, S1, L5, L4, L3, L2. So your tip here is, just below the level of L1, so between L1, L2, so that's a normal. You could see also this cone is lying more anteriorly because this baby is prone. You can see the end of the thecal sac here at S2. So you can also attempt to identify, the lowest rib over each kidney from the back and follow it medially to its vertebral body. So you try and find that lowest rib and follow it back to that vertebral body and then label that as your T12. And then count from T12 working caudally. So T12, L1, L2. So again, another example of a nice normal spinal cord. You can see it's line dependent where gravity has taken it. And it's got a normal terminal location between L1 and S2, so that's normal. So the spinal cord should lie 1/3 to 1/2 towards the anterior ventral vertebrae in the spinal cord. This indicates the cord's position is gravity dependent and free flowing. So again, that's what I referring to, how it's lying, on that bottom half of the vertebral canal. Normal pulsatile movement. So the spinal cord and roots of the caudae equinae are normally observed to move and may be documented with M mode or a cine clip. This is best observed when the image persistence or frame averaging is minimized. Dorsoventral oscillations occur at a frequency of the heartbeat. And there's also a superimposed motion, which occurs with respiration. So again, so you should see movements of this spinal cord and roots. Oh. So thickness of the phylum terminal. While the phylum is normally larger than the caudae equinae nerves, it should measure less than 2 millimeters. Real-time imaging should be sure to capture this structure and not just a clump of nerve roots. All right, so pathology for the neonatal spinal column. So our main one that we're going to be looking for is the occultar cord. Some other potential pathologies we might encounter, could be a lipoma, hydromyelema, diastomyelema, cysts of the spinal cord, or a myomeningocele. So tethered spinal cord. This is a pathologic fixation of the spinal cord in an abnormal caudal location. So it's a pathologic fixation of abnormal spinal cord in a lower caudal, so low down location. So with this condition, cord suffers mechanical stretching, distortion, ischemia, so lack of blood supply with daily activities, growth and development, and is often fixed eccentrically within the canal. Tethered spinal cord is a pathologic fixation of an abnormal caudal location. All right. So tethered spinal cord. As the child grows, the spinal cord is not able to grow, resulting in terrible benign consequences if not treated. Children may have pain or loose function of their legs, bowel, or bladder. Onset of symptoms is often seen around 3 years of age. So if you think about that, this poor child might be suffering, might be undiagnosed, or if it's not diagnosed early, it can lead to lasting permanent nerve damage for this child. It's unfortunate because a lot of, the symptoms that, you get from a tethered cord, you you attribute to just a normal baby. They're not really functioning using their legs. They're not up walking around. Uh, how can you tell if they don't have, proper function of their bowel or bladder? They're an infant. So unfortunately, it's not until that child gets older that you start exhibiting, the onset of symptoms or realize the onset of symptoms. So they were trying to show a tethered cord here. I didn't particularly like this picture from the slides in the textbook because it's kind of hard to see exactly where that conus is ending. I'm not sure if they're, to me, this looks more like the terminal phylum terminal coming down, and maybe the conus is in this area, and L3, maybe where that arrow is pointing to. Excuse me. So I found a better picture online. Let's see. Stop share. Excuse me. All right. So in this one, so you can see the conus coming to a point here, and they're labeling this as the L5. So you can see this is the lumbosacral junction. So this is a very low lying cord. And the other thing to appreciate is that this cord isn't line dependent now. See, it's affixed eccentrically. So it's adhered to that ventral side, dorsal side. So this is adhered more posteriorly as opposed to lying anteriorly and gravity dependent. So that should be your other clue, that, there's an issue going on. So if you can all, appreciate that. Sure. So this is a transverse view showing the conus medullaris coming to a point, and they're labeling it between the T2, T3 vertebrae. So the tethered cord diagnosis corresponds to 4 particular features pointed out in the sonographic examination, and positive signs include, so that's going to be the low-lying conus medullaris beyond the level of L2, a caudal or posterior position of the spinal cord. So it's going to be a low position of the spinal cord, absent or dampened pulsations of the spinal cord and nerve roots. So again, so you're not going to see it pulsating or moving, with the pulse and respiration. It's going to be fixed or adhered. And also a thickened phylum terminal greater than 2 millimeters. So those are going to be your 4, main criteria for diagnosing a tethered cord. Spinal cord oscillations might be diminished. If cord oscillations are present, distant from site of tethering, they're often dampened or absent closer to the point of fixation. Normal brisk oscillations of cord is not seen as apparent in normal neonates. as it is in older infants. All right, so another pathology potentially we can encounter is going to be a lipoma. So spinal lipomas are fatty masses that have a connection with the spinal cord. Lipomas can be broken down into four categories. We have intradural lipomas, lipomyoceles, lipomyomeningoceles, and fibrolipomas of the phylum terminal. So pathology of the spinal canal in this slide. So here we see what we were going to talk about is the open dysraphisms. So you can see that there's no skin covering on these deformities and this myocele and this myelomeningocele. Whereas with these deformities, we do have a skin covering. So over here, we just have a thin membrane and this defect is actually exposed. So you can actually visualize, through that thin membrane. We're not going to typically perform ultrasounds on these due to that thin membrane and, risk of puncturing or disrupting, or, you don't want to put your probe on that. So more often than not, we're going to be imaging these types of lesions that are closed dysraphisms. So L is the lipoma. So this is an intradural lipoma. Lipomyocele, lipomyomeningocele. So intradural lipomas are situated in the subpial position in dorsal cleft of the open spinal cord. Lipomyoceles are analogous to the myocele in that there's a covering of attached lipoma and intact skin. So it's similar to the myocele, just that there's a attached lipoma and an intact skin. Lipomyomeningocele is an expansion of the subarachnoid space ventral to the placoid. A fibrous lipoma of the phylum terminal is a unique form of lipoma that may represent a variant of normal development. On sonography is seen as thickened echogenic phylum terminal, sometimes with undulating contour. When associated with tethered cord, usually accompanied with a mass of the lower cord or phylum terminal. So fibrolipomas comprise 20 to 50% of spinal dysplasias and can be continuous with subcutaneous tissue and presents as a fatty lump on the lower back. Lipomas can be isolated to the phylum terminal or extend to and infiltrate the spinal cord and the conus medullaris. Lipomas usually are echogenic and may present as small or large masses, so they can vary in size. So you can see a couple different presentations for lipoma. So this is lipoma actually along the spinal canal itself. Another lipoma, within the dura mater, below the level of the dura mater. This is a lipoma, the fibrous lipoma along the phylum terminal. Again, you can see here area of the lipoma. Another second lipoma along the filum terminal. So hydromyelema can be sonographically observed abnormality of the spinal cord. There's slight prominence of the central canal at the caudal end of the cord is common finding in neonates. So focal hydromyelemia often presents with cephalid, presents just cephalid to the site of tethering, and is a dystrophic condition like myomeningocele or a lipomyomeningocele. So here we can see the prominence of the caudal portion of the spinal cord. Oh, sorry. So here again, so this is going to be that prominence of the caudal end of that spinal cord. So diastematomyelema. So this is actually a splitting of the spinal cord. So you could see two neural canals, two central canals of the spinal cord. So diastematomyelema may accompany a hydromyelema. So this is a sagittal division of cord into two hemichords, each containing a central canal and a dorsal horn and a single ventral horn. Cord is split at one or more sites by osseous cartilaginous and fibrous septums. Two segments of cord can be seen most clearly on the transverse view. So when you get your transverse view, you can appreciate, your two spinal cords. So a dermal sinus versus a polynoidal sinus. So dorsal dermal sinus is a thin tract lined with epithelium passing from the skin to the spinal canal. While they occur anywhere along the spine, they're most common in the lumbosacral region. Patients are at risk for meningitis due to this tract opening directly to the spinal canal. The dermal sinus, they often present clinically as a deep midline pits. The sinus tract will disrupt the echogenic line with the possible extension into the dura. They frequently occur in the sacral and coccygeal region and may appear as a dimple with a sacral dimple. Infection is also possible in the polynoidal sinus. Uh, a polynoidal sinus is not connected to the spinal canal, nor is associated with a tethered cord. So you have to, understand that differentiation. So this is going to be your dermal sinus over here where these arrows are pointing off the base of the coccyx. So dermal sinus, could potentially have interaction with the spinal cord, whereas the polynodal sinus is not connected to the spinal canal nor is associated with the tethered cord. So just remember that differentiating dermal sinus could have connection with the spinal cord and connection to the dura mater, increasing the risk for meningitis in these babies. So it's passes from the skin to the spinal canal with the dermal sinus. So you can also have cysts of the spinal cord, small cysts within the filum terminal, maybe remnants of that terminal ventricle or an arachnoid pseudocyst and have no significance. So if you see a cyst within that filum terminal, don't be alarmed or scared, this could just be a remnant of that terminal ventricle. Cysts in the caudae equinae region may also be seen with a thick phylum. So myelomeningocele or myeloschisis. So the primary reason for studying cord in cases of clinical observation of a myelomeningocele or myeloschisis is to exclude additional cord pathology. Oh, excuse me one second. Yeah, my wife has an appointment with my son tomorrow, and Dr. Epstein, he was going to fill out some forms for my wife, and he wanted like all of my son's medical records sent from his pediatric doctor back in New York. I believe we had signed consent, and like they had sent the medical records, but RBK Pediatrics. Okay. Yeah, this afternoon would be great. Yeah, I appreciate it. All right, thank you. All right. Sorry about that. All right, so another thing with myomeningoceles, they're actually the most common open spinal cord defect. So myomeningoceles actually make up about 98% of most open spinal defects, whereas myoceles, just a plain myocele, are rare. So myomeningoceles are the most common open spinal cord defect or open form of open dysraphism. The intraoperative sonography successfully used to detect margins of skin defect. We assess cord, anatomy of cord, adhesion of cord to the dorsal aspect of the spinal canal, cephalad to the defect. Appearance of the neural placoid and nerve roots in the defect can also be seen on sonogram. So myomeningocele shows a flat, non-tubulated cord with nerve roots extending into defect. Nerve roots rise from the neural plicoid and with dorsal roots lateral and ventral roots medial. Meningocele shows nothing but fluid within the sac. Meningoceles can contain fine lace-like strands extending into the sac. The fibers are finer than nerve roots and are strands of thin lining of tissue, such as the subarachnoid, or such as arachnoid. Spinal cord is tabulated and does not enter the sac in a meningocele. The cord might be focally eccentric in the canal and be tethered to a focal adhesion. So here you could see some of that cord tethering down. Outer borders or outer layers of that cord. So you can see this large meningocele, the fluid around it. So this is a good example showing. So this is just a plain meningocele with no cord within it. Then a myelomeningocele is when you have entrance of cord within that seal or cystic area. So again, this is going to be, oh, sorry. So these are considered open forms of dysraphism where there's no skin covering. So this is going to be exposed, just a thin membrane, covering this area. Other indications and associations. So midline cutaneous abnormalities over the lower back are the most common reason for a neonatal spinal request. So those are going to be, a palpable mass, a visible mass or lesion, sacral dimple, that's more than 2.5 centimeters above the anus. That's more than 5 millimeters in diameter. An abnormally deep sacral dimple. Also, some other midline abnormalities could be an imperforate anus or a tuft of hair along the lumbosacral, a thick tuft of hair along the lumbosacral region. Midline dimples over the lower back occur approximately 2% to 4.3% of newborns. Most are low sacral coccygeal pits without associated tethered cord. Sometimes the track can sometimes be seen and followed. So you can also potentially also have leakage of fluid through the dimple or midline pit that you see. So that can also be something that could be alarming or a cause for examination. If there's any fluid leakage through that dimple. Track can be seen and followed, especially if it is fluid filled or if it disrupts normal soft tissue planes. So we also assess the soft tissue interfaces. So we look for continuous echogenic lines between the skin, subcutaneous fat, muscle, and fascia. Sinus tracts will disrupt the echogenic line with possible extension into the dura. Dural penetration sometimes is difficult to ascertain or exclude on sonography. So in those cases, they will potentially do an MRI. The neonatal coccyx is usually very low echogenicity and should not be mistaken for a cyst or fluid collection. So some other indications or associations. So I said those midline hair patches, any fatty lumps, skin tags, pigmented nevi, lumbar dimples, Aplasia cutis and hemangiomas over the back should prompt a search for occult tethered spinal cord. Hemangiomas seem to have a high association with a tethered spinal cord, so keep that into consideration. So hemangiomas, it's also important to remember the difference, between your Mongolian spot, which could potentially be normal, versus, discoloration or hemangioma. Tether cord has association with neonates with an imperforate anus. Mentioned that. So an epidural hematoma. So failed spinal taps or lumbar punctures often are associated with epidural hematoma. So you can see in these areas of the star here, getting epidural hematomas. Share screen. So this was another picture showing myomeningocele. So your normal, spinal canal and brain anatomy. So there's a couple different things that can occur with spina bifida. So if a patient, has a Chiari malformation, we have dilatation of the ventricles, which creates pressure, within the brain. So these ventricles are dilating, putting pressure on the skull. So everything gets pushed caudally now. So you get continued pressure pushes the brain out through the bottom of the skull. So you have, a caudal progression of the cerebellum as well as the spinal cord. So this is your Arnold Chiari malformation, which then, pushes the spinal cord down and can lead to this development of the myomeningocele. So the caudae quanae of the spinal cord protruding out into the myomeningocele. So this is an example of, your spina bifida. There's an exposed membrane. So this is open dysraphism. If there's a closed dysraphism, you'd have continuation of the skin covering, this defect. So that's the difference between an open versus a closed dysraphism. So any questions about this type of exam? They're fairly easy to do and perform actually. So I use the highest frequency probe that I have. Our lab, they liked us to use actually this 18 megahertz linear probe that had a very wide footprint on it. It's the same one that we'd use, for like a testicular exam or so you can see, very superficial. It gives you very good detail and acquire panoramic view starting at the coccyx and working your way up, imaging the sacral vertebrae, working your way up to the lumbar vertebrae, up to that T12 junction. And, making sure you count your spaces correctly. You don't want to give this baby a low lying cord. If it's not really a low lying, if you miscounted one. In addition, you also want to look at the position of the cord, making sure that it's lying anteriorly, so it's gravity dependent. You're looking for oscillations and movement of the cord, to rule out that it's not tethered. In terms of the phylum terminal, should be 2 millimeters or less in diameter. So you want to make sure it's not thickened. Yeah, so it's not a difficult exam. Doesn't take very long. But again, it's one of those exams that, people tend to get scared of. Like, oh my God, I can't do that. Like, or afraid to touch or do, and they're not difficult. So don't be afraid of peds. It's my general message. It's actually easier than adults if they behave. But any questions about any of this? No, no, it's not too bad. All right, so I'm going to sign off. I'll see you guys back at 10 o'clock. Go through scanning applications, that quiz, and then you guys come in for lab.
Thank you.
All right, I'll see you.
Thank you. Bye-bye.
Bye.